Very good evening. Very good evening, guys. Welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. Very good evening. Very good evening. These are just questions, right? So we are going to quickly revise past 5 years question papers today through this session. All of you would have read these questions already, so I want you to actively participate in just quick recap of the entire 5 years question papers, right? So very good evening to all of you. Myself, I am Dr. Ramyasree. I teach obstetrics and gynecology. So today, I will finish past 5 years questions of obstetrics and gynecology through this video to all of you, right? So let us start with the session. So first, we are starting with 2023 questions. A female with multiple sexual partners came with the complaints of fever. On examination, there is swelling of labia majora, which is tender and red. What is the diagnosis? So swelling of the labia majora, what do you think this might be? It's very simple here. Any swelling of the labia majora, close your eyes and answer only for Bartholin abscess. It's mainly for the Bartholin abscess, right? See, chlamydia trachomatis mainly causes cervicitis. Herpes will lead to painless ulcer, painful ulcer. It will cause multiple blisters on the vulva. Syphilis will lead to painless ulcers. Swelling in the labia majora is mainly caused by Bartholin abscess, right? So Bartholin abscess will be a posterolateral cyst, which is at the junction of upper 2/3 and lower 1/3. See, it is not the question which will repeat, it is the concept which will repeat. So I want you to answer few more questions on this. Which is the most common organism which can cause Bartholin abscess? What is the treatment for Bartholin abscess? So it is a fluctuant, tender swelling present at the junction of upper 2/3 and lower 1/3, right? So what is the most common organism which causes Bartholin abscess? And what is the treatment for Bartholin abscess? So the most common organism which causes Bartholin abscess is E. coli. Treatment is incision and drainage. Bartholin cyst is non-tender. Bartholin cyst is non-tender. Treatment for Bartholin cyst is also incision and drainage. But if they ask you the best treatment and to prevent recurrence, what is the best treatment to prevent the recurrence? Then what I am showing you in this picture, you have to answer this. What is this? Yes, best treatment and the treatment to prevent the recurrence is marsupialization. So what is this marsupialization? You remove the cyst and you suture the cyst wall. So you suture the cyst wall, you don't close it. As you're going to suture the cyst walls and keep it open, all the secretions will get drained outside. Last question. What is the other name for Bartholin gland? Where is Bartholin gland present? What is the other name for Bartholin gland? And where is Bartholin gland present? So Bartholin gland is also called as greater vestibular gland. It's also called as greater vestibular gland. And this is present in the superficial perineal pouch. This is homologous to bulbourethral gland in males. See, when I tell some topic, how should be your preparation is, if I am telling Bartholin gland, everything about Bartholin gland should fatafat come in your brain. Okay, let's go to the next question now. So this is homologous to bulbourethral gland. Bulbourethral gland in males will be present in deep perineal pouch. This question, I don't know what it is so favorable for them, but this has come twice in your PYQs. Now you'll see this question twice. A lady who is 38 weeks pregnant comes to the OPD for a routine checkup. She has a normal twin delivery at 4 years ago. What is her gravidan para score? So gravida means total number of pregnancies irrespective of the outcome. Gravida means total number of pregnancies irrespective of the outcome, and gravida also includes the current pregnancy. So she got pregnant twice. Para means all those pregnancies which has crossed the period of viability. Twins, although the outcome of the babies is 2, but pregnancy will be 1. So this is G2 P1. Can you tell me the full obstetric score of this? It will be G2 P1 L2. G2 P1 L2. Please never answer G2 P2. Never answer G2 P2, guys. Because twins, although it is one pregnancy. वेंकटेश से बात करो आप उसको बुलाओ किन्नी खेलो प्लीज वेदांशी आई एम इन अ क्लास पापा उड़ले I'm very sorry. So it's gravida 2, para 1, living 2. So twins may it will be total number of pregnancies that have crossed the period of viability. In India, period of viability should be taken as 24 weeks. Actually, according to American College of Obstetrics and Gynecology, it is 20 weeks. But in India, it is 24 weeks. All previous pregnancies that have crossed the period of viability, you are going to include in the para. Twins may para will be 1, gravida will be counted 1, but number of outcomes will be 2. A 24-year-old pregnant woman came for an antenatal checkup. Her hemoglobin is 9.4. What will you advise her as she is currently 9 weeks pregnant? I know you all know the answer for this, but I would quickly recap one thing for you all and then I will go back to the question. So we have to treat anemia in pregnancy as per Anemia Mukt Bharat. As per Anemia Mukt Bharat, right? So mild anemia is 10 to 10.9 gram per deciliter. Moderate anemia is 7 to 9.9 gram per deciliter. Whenever you have mild or moderate anemia, less than 30 weeks of gestation, give her 2 tablets of oral iron. Give her 2 tablets of oral iron. So normally we give 1 tablet of oral iron. No, here we have to give 2 tablets of oral iron till hemoglobin normalizes. I want you to write in the comment box what is the dose of the iron which we normally give as per Anemia Mukt Bharat. More than 30 weeks of gestation, you will give parenteral iron. The 2 commonly used parenteral iron are iron sucrose and ferricarboxymaltose. So less than 30 weeks of gestation, you will give 2 tablets of oral iron till hemoglobin normalizes. More than 30 weeks of gestation, you will give parenteral iron, that is either iron sucrose or ferricarboxymaltose. Iron sucrose is 200 milligrams IV, whereas ferricarboxymaltose is 1000 milligrams IV. Right? Yes, excellent. I would have been more happy if you would have written 60 milligrams of elemental iron plus 500 micrograms of folic acid for 180 days in pregnancy and 180 days postpartum. Right? So, 1 tablet of oral iron contains 60 milligrams of elemental iron plus 500 micrograms of folic acid for 180 days in pregnancy and 180 days postpartum. Correct? Okay, next. You're going to imprint all this along with me. Severe anemia. If it is less than 5 gram per deciliter, whatever might be the gestational age, you will do blood transfusion. Blood transfusion irrespective of the gestational age. Irrespective of gestational age. And if the hemoglobin is between 5 to 6.9 gram per deciliter. Less than 34 weeks, it is parenteral iron. More than 34 weeks, it is blood transfusion. In blood transfusion also, you will mainly give packed cell transfusion. In blood transfusion also, you will give packed cell transfusion. So this is the most important, guys. This is the most important. Okay? Okay, now I am going to go back to the question. 24-year-old has got anemia of 9.4. So 9.4 is mild anemia or moderate anemia or severe anemia. So 7 to 9.9 is moderate anemia. Moderate anemia at how many weeks? 9 weeks. As per our graph, what did I tell you? Less than 30 weeks, you have to start her on oral tablets. How many oral tablets? Ideally 2 oral tablets. When she has anemia, you will start now or you will start later. Today I am having pain, you will tell, wait, I will see one good muhurtam and treat. That is not correct, na? So start iron tablets from now itself. So take iron tablets from now itself, right? So iron is not teratogenic, but iron is nauseating. That's why we don't regularly give in first trimester. And the need for iron in the first trimester is very minimal, which can be taken by diet. That's why we don't give normally in the first trimester. But somebody who's anemic, you have to start from first trimester itself. Okay? Right. Let us go to the next question now. A patient with period of gestation of 32 weeks presents with difficulty in breathing and respiration. On examination, abdominal distension is there, but no tenderness. Fetal parts are not palpable. Fetal movements are normal. Symphysia fundal height is 41 centimeters. What is your diagnosis? Now, first answer which I'll rule out here is PIH. First answer which I'll rule out is PIH. Kyuki in PIH, although I know the answer, I will again approach it. You also have to do same in the exam. Please see with all 4 options. PIH, why am I ruling out? PIH mein uterus can be less than period of gestation, not more than. Kyuki in PIH, you will have IUGR fetus. Now this can be polyhydramnios, macrosomia and twins. But in twins, you will have fetal parts will be palpable more, not palpable. So this cannot be twins. Polyhydramnios, that is when you have excess amniotic fluid, you cannot palpate the fetal parts easily, but uterus will not be tender. So this is very classical explanation of polyhydramnios, right? So this is nothing but polyhydramnios. Correct. Next, see how simple questions you will get. A pregnant female complains of dizziness on lying down but relieves on sitting up or lying lateral. Why? Quickly, this also you all know. We have we discussed so many times. So why does somebody get dizziness in pregnancy? It's mainly because of compression of what? I want you to precisely write which vein compression. It's mainly due to vena cava compression. Which vena cava compression? It's mainly due to inferior vena cava compression. This is also called as supine hypotension syndrome. Supine hypotension syndrome. Or it's also called as inferior vena cava compression syndrome. That's why in 3rd trimester, you ask the pregnant woman to lie down in a left lateral position. Right? Okay, so this is the supine hypotension or inferior vena cava compression. That is why she should lie down in left lateral position. Okay, next question. See, you get lot of questions on amenorrhea. So I will take little time here and I will tell you how we should approach a case of amenorrhea. A 15-year-old patient came with her mother with complaints of primary amenorrhea on physical examination. Okay, first I'll tell you how to approach and then I'll come back to this question. So whenever you have a case of primary amenorrhea, ask yourself whether secondary sexual characteristics are present or absent. If secondary sexual characteristics are positive, but uterus is absent, what are your differential diagnoses for secondary sexual characteristics positive, but uterus is absent? First, I want you to answer for this point. Secondary sexual characteristics, that is breast is present but uterus is not there. So for this you have MRKH. Okay, some topics let's go little slow because this topic will repeat multiple times. So uterus is absent can be MRKH, AIS, androgen insensitivity syndrome, and 5-alpha reductase deficiency. Correct? Now again, how will I differentiate between these three? So whenever first secondary sexual characteristics positive, uterus is absent, if they tell, you go for these three. Now in this three, MRKH is 46XX and MRKH में axillary and pubic hair positive. Okay. AIS, it is testosterone receptor defect. So it is 46XY. Here axillary and pubic hair are absent. Axillary and pubic hair are absent. But breast is present in both of them. Breast positive. 5-alpha reductase deficiency. 5-alpha reductase deficiency. It is also 46XY. And what happens here? Because of the 5-alpha reductase deficiency, testosterone is not getting converted into dihydrotestosterone. Because of that, they'll have female external genitalia. So this patient will present to you with virilization. They're actually male, so they'll have virilization. Am I clear with this point? Now let's see the next table. If secondary sexual characteristics are negative and uterus is present, what are the differential diagnoses we have here? Turner's, Swayer's, Kallman's. Now how am I going to differentiate between these three? Turner's is 45XO, Swayer's is 46XY, Kallman's is 46XX. And Turner will have short stature. Simple. Just see these. I am asking you to remember 6 things in your brain. Yeah. So, agar uterus absent hai, these 3 differential diagnoses, uterus present, think in terms of this. Okay. And here uterus will be present, but secondary sexual characteristics will be negative. Here secondary sexual characteristics will be positive, uterus is absent. I hope I have simplified it. Let's go to the question now. 15-year-old comes with her mother with complaints of primary amenorrhea on physical examination. It was revealed that breasts are present, but no pubic hair. On TVS, fallopian tubes and ovaries were not seen. Inguinal region shows swelling is seen. What is the most probable diagnosis of the patient? Now, to be frank, in our PYQ, it is showing this question, but actually this question is little different in other PYQs. I will explain that also. First, you answer with respect to this question. So, I think all of you have mentioned yes. So, as uterus is absent, I am going to go in terms of it cannot be Turner's. It can be Mullerian agenesis. It can be hypergonadotrophic hypogonadism. It can be AIS. Now, as breast are present but no pubic hair, it cannot be Mullerian agenesis. Mullerian agenesis mein you will have breast as well as pubic hair. So, this is AIS. This is AIS. Now, some books may the PYQ is little different. So, there they have given that breast is also absent. Now, if breast is also absent, first and foremost, this cannot be Turner's. This cannot be Mullerian agenesis. If breast is absent, it cannot be AIS also. So, then it goes in terms of hypergonadotrophic hypogonadism. So, again, it is a case of gonadal failure. It is a case of gonadal failure. So, it can be there are so many mutations. There are so many mutations. So, it can be a testicular mutation which has led to inguinal swelling and no uterus. And they are not having the testosterone also. That is why the breast is also absent. Breast or pubic hair, nothing is there. Okay. So, it's a complete gonadal failure in males. Then, so that is why you can answer it as hypergonadotrophic hypogonadism. So, whenever you have a case of amenorrhea, ask yourself with respect to all 4 options. Ask yourself with respect to all 4 options. Then you will be able to answer better. A primigravida with UPT positive and HCG 2800. 6 weeks amenorrhea, palpable mass on left side. USG fetal cardiac activity is absent. Vitals are stable. What is the appropriate management? Now I know that you all know answer, but I will quickly recap the management of ectopic. So can you identify this is ectopic? What was the clue which they have given that this is an ectopic? Mass on the left side. That is the biggest clue which they have given that this is an ectopic, right? So now there are 3 modalities of management for ectopic: expectant management, medical management, and surgical management. The criteria for expectant and medical is same. Everything is ulta to surgical. So expectant, patient is ready for follow-up. Same for medical management. Surgical management, not ready for follow-up. Mild or no pain. Same for medical management. Significant pain in surgical. Next, sac size less than 3.5 centimeters as per the NICE guidelines, because Datta like other standard books gives 4 centimeters also, but as per the NICE guidelines, sac size less than 3.5 and FHR absent. Here sac size more than 3.5, FHR present. Beta HCG for expectant management should be less than 1000. For medical management, it should be less than 5000. For surgical management, it should be more than 5000. What is the drug of choice for medical management? Drug of choice for medical management is methotrexate. Is it single dose is as preferable than as multiple dose regimen? So it is injection methotrexate, injection, IM it is 50 milligram per meter square, IM. Best management for surgery is salpingectomy, that is complete removal of the tube. Best management for surgery is salpingectomy. After you do medical management, you have to measure the beta HCG levels on day 1, day 1, day 4, day 7. If the drop in beta HCG is more than 15%, patient is responding. Okay, you got this question twice. So now she is a primey. Okay, HCG is 2800. So this is telling me that I have to go for medical management, right? Cardiac activity is also absent. Wonderful, right? Everything is favorable for medical management. Now, is it oral or is it methotrexate and leucovorin, or is it injection methotrexate? So it is injection methotrexate, single dose, 50 milligram per meter square. Okay, let us go to the next question. A 24-year-old female presents at 36 weeks plus 6 days. On examination, the fetus was transverse lie with adequate liquor. Placenta is normal position. Weight of the baby is 2.8 kgs. What is the next step in the management? I want you people to answer this. Yes, whenever you have transverse lie from 36 weeks to term, when patient is not in labor, you can always try ECV. So excellent, guys. It's ECV. Okay, external cephalic version. If ECV fails, you can repeat ECV. If ECV fails twice, then you go for LSCS. But if you have the same question, 36 weeks plus 6 days gestation, patient is in labor. Now I change the question that patient is in labor. Then what should be your answer? Same question, 36 weeks plus 6 days and patient is in labor. Uterus is contracting. Now what will be the answer? Will it be emergency cesarean or ECV or vacuum or internal podalic version? Now the answer will change to emergency cesarean. Now the answer will change to emergency cesarean. Okay. There is no role of vaginal delivery in transverse drive. If ECV is successful, then vaginal delivery. But ECV is not successful, you have to go for cesarean. Where do we do internal podalic version? Internal podalic version is done only in transverse lie in second twin. Transverse lie in second twin, there only we do IPV. Otherwise, we don't do IPV. Okay. Very good. Excellent. Let's go to the next question now. Anxious mother-in-law comes with daughter-in-law. See, I always tell, no, this is the combination which everyone, they come. Anxious mother-in-law comes with daughter-in-law after 6 months of marriage. 6 months only. And cohabitation. They've been trying for 6 months to give her a grandchild. What do you advise? Yeah. So reassure her and come after 6 months. Okay. So reassure and come after 6 months. Now, same question, I change it to anxious mother-in-law and daughter-in-law come after 1 year of the marriage and they've been trying to give her grandchild from 1 year. And what do you advise? Now, what will be your answer? Same options. So, if anxious mother-in-law comes with daughter-in-law after 1 year of marriage and they're not able to give the grandchild, then yeah, you have to check for the infertility. I'll tell, bring husband, bring the son and do, yes, husband semen analysis is indicated then. Correct, guys. Very good. Excellent. When is iron given to a pregnant female? When is ideally iron given to a pregnant female? So iron should be, iron and calcium are started in the second trimester. Iron and calcium are started in second trimester. As of now, earlier we used to start from 12 weeks, guys. But now second trimester has been changed to 14 weeks. So we start around 14 weeks. Prophylactically, earlier we used to start from 12 weeks. But now second trimester has been changed to 14 weeks, no? So you can start from 14 weeks. If somebody is anemic, now please, I want you to understand one important point. If somebody is anemic, then start at that time only. Otherwise, prophylactically from second trimester. If you have an option of 14 weeks, go for 14 weeks. If you have an option of 12 to 14 weeks, go for 12 to 14 weeks also. That's fair enough. Okay. Right, let's go to the next question. Female with lower abdominal pain for 1 month history. Female with lower abdomen for 1 month. She has a history of multiple sexual partners. So I am thinking in terms of STD now. She has mild intermenstrual bleeding, scanty vaginal discharge, but she has dysuria. What is the most likely causative organism? Now, can it be TB? TB is common in virgin females. TB does not cause dysuria. TB mainly causes salpingitis. Can it be herpes? Herpes causes multiple small ulcers, painful ulcers. Candida causes curdy white discharge. So what is this? This is gonorrhea. This is gonorrhea. So gonorrhea will cause this gonococcal urethritis. Gonococcal urethritis. And it can cause cervicitis. Diagnosis, mainly you do nucleic acid amplification test or culture on Thayer-Martin medium. Culture on Thayer-Martin medium. Drug of choice, injection ceftriaxone. Injection ceftriaxone, 125 milligrams IM single dose. You can give from 125 to 250 milligrams depending on the weight. So single dose. Another asymptomatic cervicitis is caused by chlamydia trachomatis. Asymptomatic cervicitis is caused by Chlamydia trachomatis. Chlamydia trachomatis is also diagnosed by nucleic acid amplification test. Chlamydia drug of choice is azithromycin 1 gram stat dose or doxycycline 100 milligrams BD. Azithromycin only. Azithromycin is the most important. Now, do you want to treat her partner also? Partners also? Yes. You have to trace her partners and treat all the partners. It's an STD. Yes. Next. I don't know why, but this is one of the favorite question. You got this in the NEET and you got recent tiny CT also this question. So this is like a grace mark, guys. If you get this question, if you lose a mark, matlab, it is a grace mark if you get this question. 16-year-old, I'm not going to spend much time on this question. 16-year-old female with primary amenorrhea and cyclical pain abdomen on physical examination has a suprapubic bulge. Why is this suprapubic bulge? Whenever there is accumulation of blood in the vagina, it can compress the urethra and it can lead to acute retention of urine. On perrectal, there is swelling whole length of the vagina. What is your diagnosis? Imperforate hymen. Now, I want you to tell me, how do you differentiate imperforate hymen from transverse vaginal septum? Both imperforate hymen and transverse vaginal septum will present you with cyclical abdominal pain. But imperforate hymen will have swelling throughout the length of the vagina, whereas transverse vaginal septum, when you do perrectal, it will show swelling only in the upper part of vagina. Swelling only in the upper part of vagina. Only in the upper part of vagina you can have a bulge. Bulge will be only in the upper part. Till, see, imagine if this is a vagina and there is a transverse vaginal septum here. Now this part of the vagina will bulge, no? So you can feel the bulge only in the upper part of the vagina. Okay? And in transverse vaginal septum, no bluish hymen. No bluish hymen. Although here they didn't give bluish hymen, in imperforate hymen you will normally see bluish hymen. Okay? Right. A 14-year-old girl's mother has a history of cervical cancer. She was operated on. For the same, what advice would you give to the girl? Do BRCA gene testing, do B10 gene testing, give HPV vaccination, do HPV DNA testing. 14-year-old girl, what is the advice you will give? Yes, cervical cancer does not run in families. If she was having ovarian cancer, then my answer would have gone for BRCA gene testing. So I will give her advice to take the HPV vaccination. At least you take. Hai na? So it will be mainly HPV vaccination. Now, I don't know, somehow my gut feel tells this question might come. This is an update. So WHO has decided to eliminate CA cervix. Eliminate CA cervix by 2030. WHO has decided to eliminate the CA cervix by 2030. So for that, it has raised something called as 90, 70, 90. So it tells 90% of the girls less than 15 years should be vaccinated with single dose of HPV. Vaccinated. 70% of the girls, 70% of the women of 35 to 45 years should be screened by high performance testing. Should be screened by high performance testing. And 90% should receive, 90% women with CIN or CA cervix should receive treatment. CIN or CA cervix should receive treatment. So it is a 90, 70, 90. 90% of the girls less than 15 years should be vaccinated. 70% 35 to 45 years should be screened by high performance testing. 90% women with CIN or CA cervix should receive treatment. Two questions to you. What is the newer Indian vaccine? Newer HPV quadrivalent vaccine which has been introduced by India. Serum Institute of India. Our own quadrivalent vaccine name is Sarvavac. Sarvavac. It contains HPV 6, 11, 16, 18. HPV vaccine is made up of what? HPV vaccine is made up of L1 capsid protein. L1 capsid protein. It is not Cervarix. It is Cervavac. Cervavac. Vac. Next question. Yeah, you got 2 questions on cervical cancer. Yeah. So now I know it is like draining, but just stay with me for next 10 minutes. Next 10 minutes, I'll quickly recap the entire cervical cancer and then management of cervical cancer. So my mnemonic for learning the cervical cancer, those who are not my students, this is like wonderful if you learn this. So my mnemonic to understand the staging of cervical cancer, it is move, PM, introduce virus-like particle to blackmail corona. Move, PM, introduce virus-like particle to blackmail corona. Move is stage 1. Stage 1 is confined to cervix. It's confined to cervix. Stage 2 is parametrium. All about parametrium. Stage 3 is lateral pelvic wall. Stage 4 is bowel and bladder and distendments. Okay. Now if I go back to the question, it is extended to left parametrium with lateral wall involvement. See, even if I don't know the entire staging, those who have already whenever, see, second stage is about parametrium. If parametrium is not involved, it will be 2A. If parametrium is involved, it is 2B. B matlab both sides. Third stage is about the lateral pelvic wall. If lateral pelvic wall is involved, it is 3B. If lateral pelvic wall is not involved, it is 3A. I'll quickly recap the entire cervical cancer. Just stay with me. So 1A1, stage 1 is entire confined to cervix. 1A1 and 1A2 are microscopic. That is why M. Microscopic M. So 1A1 is less than 3 mm in depth, stromal depth. 1A2 is 3 to 5 mm in stromal depth. I want you to revise it along with me now. V means visible. M means microscopy. V means visible. 1B1, 1B2, 1B3. All these are more than 5 mm in depth. But size is different. 1B1 is less than 2 centimeters. 1B2 is 2 to 4 centimeters. 1B3 is more than 4 centimeters. Always remember, whenever the tumor size is more than 4, you cannot give surgical management. Ho gaya? Stage 1 registered. Stage 1 mein at least what are you going to remember? 1A1, 1A2 are microscopic. 1B1, 1B2, 1B3 are visible. More than 5 mm in depth and size. This is size of the tumor. Less than 2 centimeter size, 2 to 4 centimeter size, more than 4 centimeter size. But all this is confined to cervix. Now cervical cancer can spread where? The nearest where it can spread to the vagina. Stage 2 is upper 2/3 of vagina involved. Upper 2/3 of vagina involved. So what is my mnemonic? Move PM. Stage 2 is PM. PM stands for parametrium. 2A means without parametrial involvement. A is always without. 2A1 less than 4 centimeters. 2A2 more than 4 centimeters. 2B is with parametrial involvement. 2B is with parametrial involvement. Okay? Right. Coming to the third stage. Now what is left? Lower 1/3 of vagina. Stage 3, lower 1/3 of vagina. What is my mnemonic for lower stage 3? Virus-like particle. LP. V vagina. LP stands for lateral pelvic wall. So the key word for third stage is lateral pelvic wall. 3A means without lateral pelvic wall. Always A means without. Okay? Without lateral pelvic wall. 3B matlab, B matlab baju, both sides. With lateral pelvic wall. While it is going to lateral pelvic wall, it will touch ureter. It will tell hi. So hydroureter, hydronephrosis, and non-functioning kidney also will be included here. 3C1 pelvic lymph nodes, 3C2 para-aortic lymph nodes, 3C2 para-aortic lymph nodes. Fourth stage, blackmail. Fourth stage is blackmail. So 4A, bowel and bladder. 4B, distant mets, superficial inguinal lymph nodes and all will come in 4B. So BM, blackmail. Move, microscopy visible. PM, parametrium. Virus-like particle, vagina, lateral pelvic wall, blackmail, corona. Nice. Management. Grossly, I want you to remember, staging starts from which stage, guys? 1A1. So 1A1, write A1 the other side also. What comes after 1? 2. So 1A1 to 2A1, surgical management. Except 1B3, because tumor is very big there. So 2A2 to 4B and 1B3. You will do concurrent chemoradiotherapy. That is, you will give chemotherapy with cisplatin. You will give first chemotherapy with cisplatin, followed by you will do radiotherapy. Surgery mein, how will you remember which surgery for what stage? So this I remember from down. 1B1, 1B2, 2A1. B looks like which number, guys? B looks like which number, guys? B looks like 3, no? So we'll do type 3 hysterectomy. That's also called as radical hysterectomy. So for 1B1, see B looks like 3. So 1B1, 1B2 and 2A1. We do type 3 hysterectomy. Guys, listen to me. You'll thank me later because this are going to come and you're going to listen this. आपको याद आएगा एग्जाम में जब मैं ये बोल रही हूँ. Type 3 hysterectomy plus pelvic lymphadenectomy. Remember, you will never remove ovaries here. You will never remove ovaries here. Okay? For 1A1, 1A2, it is type 2 hysterectomy or Wertham's hysterectomy. Type 2 hysterectomy plus pelvic lymphadenectomy. You will never remove ovaries here. You will never remove ovaries here. Now, those who want to preserve their uterus, just one more point. Those who want to preserve uterus, 1A1 conization, only for 1A2 and 1B1. That's all we can do. We'll go for radical trachelectomy. That is, you will remove cervix, cervical amputation till cancer free. Till cancer free. Now let us go back and let us see how much you could retain what all I have told. Okay? Chalo. First you tell me the stage, guys. First you tell me the stage. Female gives a history of multiple sexual partners, is diagnosed with cervical cancer extending to left parametrium and lateral pelvic wall. What treatment option would you suggest? First you tell me the stage, then automatically we'll understand the management. Staging batao. Lateral pelvic wall is involved. Which stage is lateral pelvic wall? Move PM virus-like particle to blackmail. So lateral pelvic wall is, tell me the stage. I don't want the answer. Tell me the stage. Always clinical question में पहले diagnosis फिर management. Excellent. This is 3B. This is 3B. And what did I tell you? Only from this is 3B. Whenever lateral pelvic wall is involved, it is 3B. So only from 1A1 to 2A1 you will do surgery. So rest all stages it is concurrent chemo radiotherapy. So what should be the answer here? Radiotherapy, chemotherapy, surgery, chemoradiation. So it is chemoradiation. Chemoradiation. So first chemotherapy with cisplatin followed by either extrinsic beam radiotherapy or brachytherapy. Simple. Did I simplify it? Give me a thumbs up if I simplified the cervical cancer for all of you. Right. So in cancer cervix, neoadjuvant therapy is given along with surgery, along with radiotherapy, after radical surgery, before radical surgery. Neoadjuvant therapy means nothing but cisplatin. So cisplatin is given along with surgery, along with radiotherapy, after radical surgery or before radical surgery. So it is concurrent chemoradiotherapy. See, if we are giving neoadjuvant therapy, it is going to be given cisplatin followed by radiotherapy. It is not at all with surgery, no. So what is the only option available here? Along with radiotherapy. It's concurrent with radiotherapy, no. So we give cisplatin and then we'll do radiotherapy. So along with radiotherapy. Okay. No, you don't do it with surgery. Are we giving any chemotherapy before surgery? No. We are giving concurrent chemoradiotherapy. Concurrent means along with radiotherapy. पहले एक डोज देके रेडियोथेरेपी तुरंत कर रहे हो, तो दैट इज व्हाई along with radiotherapy. Am I clear with this question also? Yes, many of you have answered D. You're not giving before surgery, you're giving before radiotherapy. So along with radiotherapy is a better answer. That is why, as you're giving along with radiotherapy, that is why you're calling it as concurrent chemoradiotherapy. That finishes 23. Now coming to 22. I really wanted to speak about this question, you know. I don't know, like so many students keep on messaging this question every day. Literally one person at least sends me this question. Please, everyone, whoever are asking me this question, listen to me today through this video. Post delivery, the day of delivery is called as, the day of delivery is called as day 0. Day 0. Day 0, uterus will be just below the umbilicus. Uterus just below the umbilicus. Day 1, every day it will come down by 1 finger breadth, guys. Day 1, it reduces by 1.25 centimeters below the umbilicus. That is 1 finger breadth less. So it becomes 1 finger below umbilicus. Similarly, day 2, it will become 2 finger below the umbilicus. I repeat again, what is the concept here? So post delivery, this is called involution of the uterus. Post delivery uterus will be just below the umbilicus and it remains just below the umbilicus for next 24 hours. It remains just below the umbilicus next 24 hours. Then what will happen? Day 1, it will reduce by 1 finger breadth. Day 2, it will reduce by 2 finger breadth. Day 3, it will reduce by 3 finger breadth. It's like that. Simple. So as they've asked the position of the uterus on day 2, it will be 2 finger breadths below the umbilicus. It will be 2 finger breadth below the umbilicus. So normally the uterus is 13.5 centimeters above the pubic symphysis. Every day it reduces by 1.25 centimeters. Okay. So that's called involution of the uterus. Usually by 10 to 12 days, it will become completely pelvic organ. By 10 to 12 days, it will become pelvic organ. Right? Let's go to the next question. Identify the type of hymen shown in the image below. Septate, imperforate, semilunar, annular. So I think you can see there is a septum between the hymen. So this is a septate hymen. This is a septate hymen. So this is a normal hymen. Whenever you have a septum, septate. If you see multiple perforations in the hymen, it's called cribriform. If you have no perforation, imperforate hymen, that will present you with cryptomenorrhea. If you have a small perforation, microperforate, it's called microperforate. Chalo, next question. Patient of preeclampsia post-cesarean section is on magnesium sulfate infusion. She is type 1 diabetic and her blood pressure is 280 milligram per deciliter. Always you observe most questions will have combination of 2 diseases. She is now drowsy. Her respiratory rate has become 10. There is oliguria. Patellar reflex is absent. What is the cause of her drowsiness? Is it diabetic ketoacidosis or is it magnesium sulfate toxicity? So the drug of choice for eclampsia is magnesium sulfate, right? The drug of choice for eclampsia is magnesium sulfate. You should know everything about eclampsia and magnesium sulfate, guys. So magnesium sulfate has a very narrow therapeutic range of 4 to 7 milliequivalents per liter. And whenever you are giving magnesium sulfate, you should monitor 3 things: knee jerk, respiratory rate, urine output. Why? Because magnesium is excreted unchanged in the urine. Because magnesium is excreted unchanged in the urine, you should always check urine output. She's having oliguria. So automatically the magnesium has started accumulating in her body. And that has led to both loss of patellar reflex and respiratory depression. So this is nothing but magnesium toxicity. What is the first thing to be lost whenever you're having magnesium toxicity? The first thing to be lost whenever there is magnesium toxicity is knee jerk. Knee jerk is lost first. And whenever you have loss of knee jerk, you should immediately stop magnesium sulfate till knee jerk reappears. And whenever you have oliguria or raised creatinine, what you should do? You should give half dose of magnesium sulfate. So normally we give full loading dose and maintenance dose. So here you are going to give full loading dose, but only half, you are going to give only half maintenance dose, right? So whenever you have magnesium toxicity, you will give full loading dose and half maintenance dose and half maintenance dose. Right? Okay. So I think you're all clear with this. What is the drug of choice for magnesium toxicity? Can you also tell me what is the drug of choice for magnesium toxicity? Wow, Dinesh, excellent. Right. It is calcium carbonate, 10% calcium carbonate. Next, patient with normal blood pressure, normal coagulation, AST and ALT is 75, LDH is 400, platelet count is dropped. What is your diagnosis? Is it AFLP or cholestasis or acute hepatitis or HELLP? This is very classical of HELLP, hemolysis, elevated liver enzymes, low platelet count. So HELLP is hemolysis, elevated liver enzymes and low platelet count, right? So you're having low platelet count, you're having liver enzymes elevated and hemolysis LDH 400. Everything matches. Yeah, actually AST LT should be 72. LDH should be around 600. Fine, that's okay. 400. It's matching most accurately, no? Now, AFLP mein, yeah, remember AFLP mein, AST and ALT will be in the range of 500 to thousands. Cholestasis of pregnancy will mainly present you with no jaundice, but it will present you with nocturnal pruritus in palms and soles. Nocturnal pruritus in palms and soles. And they'll have increased bile acids. Acute hepatitis will have prodromal symptoms like fever, vomiting, jaundice. Fever, vomiting and jaundice. And AST, ALT will reach very high. They're more than thousands. They're more than thousands. Okay. AFLP, I have one more question there. I'll discuss little about AFLP. Right. So this is very classical of HELLP. Next question. I feel I love this concept. Let us solve this. The patient with normal menstrual cycle and now presents with delayed menses after 2 weeks with scanty vaginal bleeding and abdominal pain. Her beta HCG is 1400. Her blood pressure is normal. USG shows trilaminar appearance in the uterus. Adnexa is normal. What is the next step? Do you know what is this called as? This is called as pregnancy of unknown location. I don't know where is the pregnancy. What is the minimum beta HCG to visualize the gestational sac? Very good. I know you all know the answers. What is the minimum beta HCG to visualize the gestational sac on transvaginal sonography? Can you answer for what I am asking? What is the minimum beta HCG to visualize the gestational sac on TVS? So this is called pregnancy of unknown location. The minimum beta HCG to visualize gestational sac is 1500 international units per liter. Some books also give it as 2000. Okay. On TVS. I prefer answering 1500 to be frank. Okay. Right. So on TVS, the minimum beta HCG to visualize the gestational sac is 1500 to 2000 international units per liter. So then you have to do serial beta HCG monitoring. So when it is less than 1500, you should do serial beta HCG monitoring every 48 hours. That is why you all were telling check the beta HCG after 48 hours. As the beta HCG level is less than 1500, so you have to repeat the beta HCG after 48 hours. Right? So when you repeat the beta HCG every 48 hours, if beta HCG rises by 63%, it is intrauterine pregnancy. If beta HCG rises by 50% but less than 63%, then it is an ectopic pregnancy. If there is fall in beta HCG, then it is a failed or biochemical pregnancy. Failed or biochemical pregnancy. So the minimum beta HCG to visualize the gestational sac is 1500. So whenever beta HCG level is less than 1500, you have to do serial beta HCG monitoring every 48 hours. So if beta HCG rises by 63%, it is called intrauterine pregnancy. If it rises by 50% but less than 63, it's an ectopic pregnancy. If there is a fall in beta HCG, then you call it as failed or biochemical pregnancy. That means it's an abortion. Okay, right. So let us go to the next question now. In embryological development, what causes the release of testosterone from the testis? In embryological development, what causes the release of testosterone from the testis? So it is the HCG from the placenta. Why is it from HCG from the placenta? Because HCG is similar to alpha subunit of LH, FSH and TSH. As it is similar to LH, it will act like a LH and it will go stimulate the male fetal testis to release testosterone. Okay. Next question. Multigravida is in second stage of labor for more than 2 hours. On PV, fetal head is palpable at the level of ischial spine in right occipito-transverse. Sagittal suture is palpable in transverse diameter of the inlet. Moulding is plus plus, caput is plus plus. What is the management? So here, whenever primary may, if second stage goes up to 3 hours, and in multi, if second stage goes up to 2 hours, we call it as second stage arrest. Second stage arrest, right? And in this second stage arrest, the fetal head is arrested at the level of ischial spines. Sagittal suture is coinciding with the transverse diameter of inlet. Do you understand what they are trying to say? This is a deep transverse arrest. Please remember, whenever you have deep transverse arrest, above +2 station, whenever you have deep transverse arrest above +2 station, you will go for LSCS. Now this is at ischial spine, means it is 0 station. So as it is 0 station, you have to go for LSCS. Okay. If you have deep transverse arrest below +2 station, then you can do instrumental delivery, guys. Then you can do instrumental delivery. And in the instrument, to rotate the fetal head, vacuum is always preferred over forceps. Then if the head would have been at +3 station, my answer would have gone for vacuum. Then LSCS. Okay. Right. Which of the following is correct regarding the secondary wave of trophoblastic invasion? Which of the following is correct about the secondary wave of trophoblastic invasion? Invasion of the radial artery by cytotrophoblast, invasion of the arcuate artery by cytotrophoblast, invasion of spiral artery by villus trophoblast, invasion of spiral artery by extravillus trophoblast. Yes, it is invasion of spiral artery by extravillus trophoblast. It is invasion of spiral artery by extravillus trophoblast. Okay, previous one, if you didn't understand, once again I am repeating. Whenever you have deep transverse arrest, you have to check for the station of the fetal head. Station is above +2, you will go for LSCS. If station is below +2, station is below +2, then you have to go for instrument. Instrument mein which is preferred instrument? Vacuum is more preferred than forceps. Vacuum is more preferred than forceps. Actually, in recent tiny CET, they have asked you how to identify which instrument to be used when. Whenever you have to rotate the fetal head, go for vacuum. Okay. If the baby's head is at +3 station, already rotated, OA or OP, or rotation is less than 45 degrees, then outlet forceps is preferred. The example for outlet forceps is Wrigley's forceps. How do you decide which forceps is? By the station. You decide which forceps is by station, not by stage of labor. Okay. So if the fetal head is between 0 to +2, you put mid forceps. Current obstetrics mein mid forceps we are not at all putting, none of us are skilled. +2 to +3, low forceps. Example for low forceps is Simpson's. Simpson's has no pelvic curve. At +3 you apply outlet forceps. Example for outlet forceps is Wrigley's. Okay. Yes. Let's go to the next question. Yeah, this you already told. It is invasion of spiral artery by extravillus trophoblast. Always remember endovascular extravillus trophoblast. If I have to be precise, endovascular extravillus trophoblast. Endovascular extravillus trophoblast invade the spiral artery. Can you tell me what are the vasoconstrictors which will increase in preeclampsia and what are the vasodilators which will decrease in preeclampsia? Quickly. What are the vasoconstrictors which will increase in preeclampsia and what are the vasodilators which will decrease in preeclampsia? So vasoconstrictors which will increase are SFLT1, endoglins and thromboxane A2. Vasodilators which are going to decrease are nitric oxide, placental growth factor and VEGF and prostacyclin. Okay, chalo, I'm going to go for the next one. Yeah, this is one question which, personally I have felt little difficult to answer, being frank. So what is the contraception of choice for 18 months postpartum woman who is breastfeeding and having heavy and irregular bleeding. Okay. Now, first option which I'll rule out is copper T, guys. Why? Because copper T further will increase her heavy and irregular bleeding. Next, I don't prefer, some of your MCQ books have given Mala N, but I don't prefer Mala N here, because whenever somebody is breastfeeding, if you give OCP, you can actually give. You can give any of this. Norethistron enanthate depot injection is designed for lactation. Progestasert is also designed for lactation. है ना? Mala N also can be given, but Mala N, if you give, it decreases the breast milk production. OCPs should not be given when somebody is breastfeeding. So that is why I remove the Mala N. Now between norethistron, I am telling you the reasons also. Between norethistron and progestasert, both are progesterones. Progestasert is inserted into the uterus. Norethistron is given injectable. Now, as she is postpartum, she is a multiparous, right? She's having heavy bleeding and irregular bleeding. Both will cause irregular bleeding, but progestasert will not have systemic side effects. So between norethistron and progestasert, I prefer progestasert, because it will not have systemic side effects, and after 6 months it will lead to complete amenorrhea. So her irregular bleeding problem will also stop. That's why I'll go for progestasert, because there will be no systemic side effects. Why didn't I choose Mala N? I didn't choose Mala N because it decreases the breast milk. OCPs decrease the breast milk. Copper T I didn't choose because copper T increases the bleeding. Norethistron I didn't choose because it has systemic side effects. Yeah, that's what I'm telling you. OCP can be, that's what I told. Other platforms have different answer. That's what I'm telling. OCPs can be used beyond 18. OCPs can be used after 6 months. There is no contraindication for OCP after 6 months. Ideally, OCP is contraindicated up to 6 weeks. 6 weeks to 6 months is relative contraindication. Beyond 6 months, it's not contraindicated. But whenever somebody is breastfeeding, OCP can decrease. Yes. So cervical bleeding, cervical internal os implantation will always cause severe vaginal bleeding. Internal os implantation will always cause severe vaginal bleeding. Okay. Whereas all this will lead to hemoperitoneum. All this will lead to hemoperitoneum. Copper T, a method of contraception, is contraindicated in which of the following cases? So I've seen like many times they're asking either copper T contraindication or OCP's contraindication. So write down somewhere in the last 1 week, you'll go through the copper T and IUCD OCP's contraindication. So contraindications of copper T are any uterine malformation, uterus में कोई problem हो, right? So ruptured condom during intercourse, that is postcoital postcoital contraception में copper T is the drug of choice, right? Menstruation, obviously you can insert copper T within 10 days of the menstruation. Post-molar evacuation after trophoblastic disease, immediate delivery. Can we insert copper T immediately after delivery? Yes. You should not insert copper T after 48 hours of delivery. After 48 hours of delivery, up to 6 weeks, it should not be inserted. Immediate delivery, you can insert. Post-molar evacuation after trophoblastic disease, you will not insert copper T. What is the contraceptive of choice? Post-molar evacuation after trophoblastic disease. So I just want you to go through all the contraindications of IUCDs. So post-molar evacuation, OCPs are the contraceptive of choice. Yes. Which of the following is an absolute contraindication for cervical cerclage in a patient with cervix of 1.8 centimeters, presence of fetal fibronectin in the cervix, prolapsed membranes into vagina, ruptured membranes, posterior placenta, sorry. So ruptured membranes is absolute contraindication, right? Ruptured membranes are absolutely contraindication. So what are the contraindications of cerclage? When you have ruptured membranes, so when you have ruptured membranes, when cervix is more than 4 centimeters dilated, when there is infection, ongoing bleeding, placenta previa, when there is a dead or anomalous fetus, when there is a dead or anomalous fetus. Excellent, guys, excellent. Let us go to the next question now. Okay. Which of the following is correct regarding the recommendation after the surgery for a patient of vesico-vaginal fistula? Abstinence for 3 weeks, avoid pregnancy for 2 years. Abstinence for 3 months, avoid pregnancy for 1 year. Abstinence for 6 weeks, avoid pregnancy for 6 years. So basically, VVF is the most common fistula. Most common cause of VVF in India is obstructed labor. Obstructed labor. Right? There will be continuous passage of urine per vaginum and there won't be normal micturition. So there will be continuous passage of urine. Investigation of choice or most useful diagnostic test is cystoscopy. Surgery of choice is 3-layer technique or Lascaux technique. 3-layer technique or Lascaux technique. Post-surgery, I remember 3 numbers, 1, 2, 3. Post-surgery, 2 weeks catheterization. 1 year no pregnancy. 3 months no coitus. 3 months no coitus. So how do I remember is 1, 2, 3. 1, 2, 3 number I remember, yeah. 1 year no pregnancy. 2 weeks catheterization. 3 months no coitus. So abstinence for 3 months, avoid pregnancy for 1 year. Okay. And if you detect VVF within 24 hours, repair immediately. If you detect VVF after 24 hours, repair after 6 weeks. Repair after 6 weeks. Methylene blue. Okay. So you have to fill the bladder with methylene blue dye. You have to fill the bladder with methylene blue dye. You put 3 swabs. If upper swab is wet by urine, but not by, if upper swab is wet by urine, but not by dye, then it is ureterovaginal fistula. If middle swab is wet by blue color, middle swab, blue color, then it is vesico-vaginal fistula. If middle and lower swab, both vesico-vaginal fistula. If only lower swab, see, then only lower swab means urethra to vagina connection. Only lower swab, blue color, then it is ureterovaginal fistula. If only lower swab is blue color, then it is ureterovaginal fistula. I'll go to the next question. Uterine artery Doppler at 12 to 14 weeks can detect which of the following? IUGR, early onset preeclampsia, late onset preeclampsia, placenta accreta. So, first and foremost, remember guys, uterine artery Doppler can tell you about mainly preeclampsia. And it can also tell you actually about placenta accreta also, to be frank, right? But 12 to 14 weeks, you will not have primary wave of trophoblastic invasion. So uterine artery Doppler will mainly tell you about the early onset preeclampsia. Okay, now take home message. Which artery Doppler will tell you about the fetal well-being? IUGR is mainly told by umbilical artery Doppler. Umbilical artery Doppler will tell you IUGR. Uterine artery Doppler, preeclampsia. Uterine artery Doppler will tell you preeclampsia. Middle cerebral artery Doppler will tell you RH isoimmunization. Will tell you RH isoimmunization. Recently in exam you got the criteria for IUGR. IUGR is whenever the estimated fetal weight is less than 10th percentile for gestational age, or abdominal circumference is also less than 10th percentile for gestational age. If it is less than 3% for the gestational age, it is called severe IUGR. If it is less than 3%, then it is severe IUGR. Which of the following MTP drugs can be used after 7 weeks of gestation? Mifi and Mitho, Miso and Mitho, Miso, Mifi, Mitho, Mifi and Miso. So Mifi and misoprostol can be used up to 9 weeks. Mifi and Miso can be used up to 9 weeks. So day 1 you will give mifepristone 200 milligrams per oral. Day 3 you will give misoprostol 400 micrograms. 800 micrograms per vaginal. 800 micrograms per vaginal. Okay. Which of the following is correct regarding the extra calorie requirement in a 12-week pregnant woman? 400 kilocalories in first trimester, 430 in third trimester, 300 in first trimester, 300 in all trimesters. Now, actually, according to Williams, no calories in first trimester. So, it cannot be 400 kilocalories in first trimester, right? Second trimester, it is 350 kilocalories. Third trimester, it is 450 kilocalories. This is as per Williams. This is as per Williams. Okay. So as per Williams, first trimester, no extra calories required. Second trimester, it is 300 calories required. Third trimester, 450 calories required. Okay. Lactation में 600 calories required. Now again, this is one more controversial question which you might see different answers in different books. I am telling you my opinion with reason. Now, as per PARC, it is 350 kilocalories throughout the pregnancy. Throughout pregnancy. Now, I don't have anything matching to Williams. Don't you agree? It is neither 300 kilocalories in first trimester nor 400 kilocalories in first trimester. Now, you have the option of 400 kilocalories in third trimester. So, third trimester is 450 kilocalories. And they have also given 300 kilocalories in third trimester, in all trimester. Which one would you prefer to use? B or C? B or D? So, you know, this is like horrible, to be frank. Now, I really wonder what examiner has thought in his brain, right? So, 400 kilocalories in third trimester, then why is he asking about 12 weeks? Hai na? So, better answer as per me will be as per the PARC itself, guys. Correct. Go for as per the PARC, that is 300 kilocalories in all trimesters. It's better to go for PARC because he's asking at 12 weeks of pregnancy. So 300 kilocalories in all trimester. So sometimes it's very difficult to get the perfect answer. Then we have to think ourselves and choose the best. Okay. On antenatal USG of a 26-year-old female, multiple fracture of long bones were identified. What is the most probable cause? Where do you see multiple fractures of long bones? Achondroplasia, Marfan syndrome, osteogenesis imperfecta, cretinism. So multiple long bone fracture is mainly seen in osteogenesis imperfecta. Osteogenesis imperfecta. Yeah, this picture has come twice, guys. Can you tell me what is this? I can see a banana shaped uterus with a beautiful one fallopian tube and dye coming out. Guys, whether it is sleeping or whether it is dancing, if you see a uterus, trace it from the cervix till the fallopian tube. So I see a banana shaped uterus, then I see a single fallopian tube and then dye coming out. So this is unicornuate uterus. Yes, this is unicornuate uterus. Next question. A woman at 26 weeks of gestation presents for routine evaluation. On examination, fundal height corresponds to 24 weeks. So although she is 26 weeks, fundal height is 24 weeks. Matlab uterus is less than period of gestation. USG shows oligohydramnios. Which of the following condition would have led to this presentation? Now remember, amniotic fluid is formed by urination. Amniotic fluid decreases by swallowing. है ना? Amniotic fluid is formed by urination. Amniotic fluid decreases by swallowing. Whenever baby is not able to pass urine, baby will have oligo. Decreased urine means all renal problems, oligo. IUGR also oligo. Decreased swallowing will be poly. Decreased swallowing will be poly. Okay. So what is this? Yes, renal agenesis will have led this. Tracheoesophageal fistula, cardiac, urethral strictures. Better than urethral strictures is renal agenesis. So I'm going for renal agenesis. Okay. A primary gravida presents to the labor room at 40 weeks of gestation with lower abdominal pain. She has been in labor for 3 hours. Which of the following determines that she is in active labor? So you have first stage from the onset of true labor pains to full dilatation. That in first stage again you have latent phase and active phase. According to Williams, latent phase is up to 6, active phase is 6 to 10. According to the recent WHO, latent phase is up to 5, active phase is 5 to 10. Fetal 5/5 palpable. No, 2 contractions, it should be 3 contractions in 10 minutes. Cervix more than 5 centimeters with complete effacement tells us that your patient is in active labor. Cervix more than 5 centimeters. So, you know, actually it should have been WHO partogram is 5 to 10. But I feel WHO partogram is outdated now. Because what is the recent WHO? Recent WHO is WHO labor care guide. So better to go with 5 to 10, yeah, 6 to 10 only. Right? Ruptured membranes doesn't tell anything. Next question. A primary gravida is brought home by relatives just after 1 hour of full-term vaginal delivery. The baby is doing well. On examination, the patient is hypotensive, hypoxic, and she has disseminated intravascular coagulation. She was previously normal with no cardiac condition. Which of the following is the most likely cause? Yes. This cannot be vaginal bleeding because they have not told she has gone into vaginal bleeding. Suddenly, patient has gone into hypoxia and DIC. This is very classical of amniotic fluid embolism. Amniotic fluid embolism. So, whenever post-delivery, suddenly somebody goes into hypoxia, hypotension and DIC, it is nothing but the amniotic fluid embolism. This has no underlying pathology. It is mainly postmortem diagnosis. What is this area which is highlighted called as? So this is called as plane of greatest pelvic dimension. It extends from posterior surface of pubic symphysis to S2, S3. This lower part is called as plane of least pelvic dimension. Plane of least pelvic dimension is from the lower border of pubic symphysis to S4, S5. And it laterally passes through ischial spines. The distance between plane of greatest pelvic dimension and least pelvic dimension is called as mid pelvis. Below the mid pelvis, you will have obstetrical outlet. Below the obstetrical outlet, you will have anatomical outlet. Always obstetrical outlet is above, anatomical outlet is below. How do I remember? OA, overaction. So obstetrical outlet is from lower border of pubic symphysis to tip of the sacrum. Anatomical outlet is from the this one is obstetrical outlet. The orange one is obstetrical outlet to tip of the sacrum. Anatomical outlet is from the lower border of pubic symphysis to tip of the coccyx. So this is obstetrical outlet. This is anatomical outlet. Obstetrical outlet is from the lower border of pubic symphysis to tip of sacrum. Anatomical outlet is from lower border of pubic symphysis to tip of coccyx. Yeah. Oh, overaction, hai na? This is enough for NEET. Ideally, I feel you should also do CET PYQs. I am doing NEET for you, no? You do CET. Right? I have so many more. Come on, let's finish it off. 34-year-old, gravida 2, para 1, living 1, previous classical is now having a breach, which is confirmed in USG at 34 weeks. The patient insists on normal delivery. What will you do? This is one of my favorite questions. So, normally up to 36 weeks, we wait and watch in breach. But here, you're not going to wait and watch. Why? Because there's no repeat USG and wait. Because she had previous classical. Once a classical, again a classical. So that's why plan classical, plan cesarean section at 37 weeks. If I would have not had in the question previous classical, then your answer would have gone for repeat USG after a week and decide. Okay? Or wait for 36 weeks. No, if I would have not given previous classical, then it would have been wait for 36 weeks. At 36 weeks, when you repeat USG, if it is still same, then you will go for ECV. The following procedure is being done on a 25-year-old lady. The cord gets torn while doing the procedure. Which of the following is the most appropriate step? So while you are doing control contraction, if cord gets cut, you have to go for manual removal of the placenta. You have to go for manual removal of the placenta. While doing this procedure, if uterus turns inside out, if there is uterine inversion, what is the immediate step you are going to do? What is the immediate step you have to do? If it is a uterine inversion, manual replacement of the uterus. Manual replacement of the uterus, followed by placenta removal, followed by injection oxytocin. Okay? Yes. No need of shifting to OT. If you have just now detected, you can just push it back. Before uterus understands it has come out, push it back. If the uterus has gone into that contracted state and if there is a vagal shock, then you will go for OT. Okay? Immediately if you have detected, then you can just push it back. 30-year-old lady who has been using OCPs for past 5 months presents with amenorrhea for last 6 weeks. Which is the best to calculate gestational age in this case? This is a missed OCP leading to pregnancy. When it is a missed OCP leading to pregnancy, you cannot calculate her gestational age by using the Naegeli's formula. So you have to go for crown rump length by USG. Then you have to go for crown rump length by USG. Wherever irregular cycles, you have to go for crown rump length by USG. If you are having IVF cycles, normally it is always Naegeli's formula. Regular cycles ke liye. Irregular cycles or OCPs and all, you will go for crown rump length by USG. IVF cycles ke liye, if you know the day of oocyte retrieval, plus 266 days. If it is day 3 embryo transfer, plus 263 days. Day 1 embryo transfer, day 5 embryo transfer, it is plus 261 days. Okay. Next question. A 28-year-old patient comes with primary infertility. HSG shows bilateral tubal block. On diagnostic hysterolaparoscopy, both cornu seems to be obstructed by a submucosal fibroid 7 into 5 and 5 into 4. Husband semen analysis found to be normal. The treatment best suited is, whenever you have a fibroids which are inhibiting the pregnancy to happen, what you should go do? Myomectomy. Remove those fibroids. Go for myomectomy. Once you do myomectomy, automatically she'll get pregnant. Whenever you have a submucous fibroid which is not letting her get pregnant, you can always go for myomectomy, guys. See, this is a repeat question. I'll not read. Please answer. Same to same. Repeat. No, it is G2P1. Okay. Now we have choriocarcinoma. So before we start with the choriocarcinoma, I'll give you a brief about choriocarcinoma. So choriocarcinoma is mainly can be seen after a molar pregnancy or after a term pregnancy or after a ectopic or abortion, anything. After any of those, you can have a molar pregnancy. So FIGO staging for molar pregnancy is stage 1 will be confined to uterus. Stage 2, you will have it spread to the outside the uterus but confined to genital structures like adnexa, vagina, broad ligament. Stage 3 is lungs. Stage 4 is brain, liver and GI tract. Correct? So they will not give you the same question. Little they can give different. So let us learn this. Stage 1 is uterus. Stage 2 other intrapelvic organs. Stage 3 lungs. Stage 4 brain, liver and GI tract. You should know the WHO prognostic scoring system. 0, 1, 2, 4. At least remember 0 column and 4 column. At least remember 0 column and 4 column. Okay? So 0 is age less than 40 years, antecedent pregnancy because of hydrated formol, interval month from index pregnancy less than 4, pre-treatment value less than 1000, larger tumor size less than 3, site of Mets lung. 4 is more than 13 interval, matlab more than 1 year. 1 lakh more than, liver and brain more than 8 Mets and previous 2 failed drugs. I will remember 0 and 4 pakka. Score less than 6, good prognosis, and it is called low risk. Score more than 6, high risk. Okay. Now simple, if you can't remember full management, at least what are you going to remember? Whenever it is low risk, you're going to give single agent chemotherapy. Whenever it is high risk, you're going to give combination chemotherapy. That's all I want you to remember. So management, yeah, I'll give you this. So stage 1, FIGO, low risk, single agent chemo. Only thing what are you going to remember? Low risk matlab single agent chemo. High risk matlab combination chemo. Stage 1, high risk, combination chemo. Plus hysterectomy, family complete. Stage 2 and 3, low risk, combination single agent chemo, low risk single agent, plus hysterectomy, family complete. 2 and 3 with low risk is single agent. High risk, combination chemo plus hysterectomy. Stage 4, combination chemo plus hysterectomy plus metastatic resection of the tumor and radiotherapy. Okay. What is the single agent chemo which we are going to give here? Injection methotrexate, 1 milligram per kg body weight on day 1, day 3, day 5, day 7, alternating with folinic acid. On day 2, day 4, day 2, day 4, day 6, day 8. This is single agent chemo. Combination chemo or macro regimen is etoposide, methotrexate, actinomycin, cyclophosphamide and vincristine. Guys, I want you to be perfect with this video. I feel there will be a lot of questions from this video, right? So going back, molar pregnancy 0 score, 25 years 0 score. Interval pregnancy less than 6 months, I don't know because I have not read that. She is having cannonball. Cannonball means lungs involved. Lungs involved means which stage? Stage 3. Cannonball is also 0. How much ever it might be 6 months, it will be less than 6 only. So stage 3 low risk. What will be the management? Stage 3 low risk. Multi-dose injection, methotrexate and folinic acid. So stage 3, methotrexate plus folinic acid. Methotrexate will lead to decrease in the folic acid levels. That's why we give along with methotrexate folinic acid. And methotrexate will cause rapid turnover of the cells. It kills all the cells. So I want folic acid to again form the cells. Low risk, less than 6 means always single agent chemo. High risk is combination chemo. I hope you understood why it is A, not D. Uterus didelphys is least common with transverse live, breach, repeated abortion, premature labor. It can be there with premature labor because didelphys uterine space is compromised, so it can go into preterm labor. They can have repeated abortion. It's more likely to have breach than transverse live. So it is least common with transverse live. Space is only not there. How it will stay in a transverse live position? Next, a primary gravida which has frequent micturition during labor with infraumbilical flattening. FHS is heard extreme in the left lateral position. What is the most probable presentation? So what is this? Guys, what are the features which are telling the answer? Whenever you have subumbilical flattening and FHR is heard in flanks, this is nothing but the Occipito-posterior. So left Occipito-posterior. Face. So it is left Occipito-posterior. Yeah. This is one question. Most students again message me. So this is one question. Please listen to me. A para-zero abortion-free patient presents with history of 3 abortions. First at 8 weeks, second at 11 weeks, third at 24 weeks. And history of early onset preeclampsia. Fetal heart rate was present in all 3 pregnancies. Which of the following is the most likely cause for her abortions? Most students will think this is Kasavitz's law and they'll go on arguing. So most students will ask why this is not syphilis. First and foremost, remember syphilis never causes recurrent abortions. It causes more of stillbirths. Okay. It causes more stillbirths. Yes, it follows Kasavitz's law, but it usually doesn't have first trimester losses. It is more progressive. Preeclampsia is mainly associated with APLA. APLA criteria is at least 1 abortion more than 10 weeks, which should be morphologically normal. So she had 1 abortion of more than 2 abortions of more than 10 weeks, which are morphologically normal fetus, and she's having preeclampsia also. This is more in favor of APLA than syphilis. Remember, syphilis causes more of stillbirths than APLA. So congenital syphilis can follow Kasavitz's law, but this is not Kasavitz's law. Okay. A woman at 36 weeks presents with painful vesicular lesions suggestive of primary herpes infection. What will be the management? Whenever you have herpes beyond 36 weeks, you will go for elective cesarean section. Recent INCT also you got this question. See, if you are perfect with herpes, you will not miss a question. No, herpes can cause neonatal meningitis. Baby comes out through that herpes lesions. Baby will have neonatal sepsis and meningitis. So never in herpes beyond 36 weeks. Even if it is not active also, beyond 36 weeks, you will go for cesarean section itself. Okay. This was asked in your recent exam. Right. We have already discussed this. Ectopic pregnancy. See how many times it is repeating. So can you answer this? 6 weeks, left adnexal mass 2 into 2 centimeters. No cardiac activity. USG shows beta HCG of 2500. What should be the management? Expectant milking, methotrexate injection, salpingectomy. So as sac size is less than 2 and beta HCG is less than 5000, you have to go for excellent methotrexate injection. Will it be single dose or multiple dose? It will be single dose. It will be single dose. You can't do expectant management. Expectant management is done when beta HCG is less than 1000. Okay, good. PPH is refractory to medical treatment. Stepwise devascularization is planned. Which all arteries are ligated? So stepwise uterine artery devascularization may you will first ligate the uterine artery near the isthmus or lower uterine segment. Then you will ligate the utero-ovarian anastomosis at the cornu. So first ligate here, then utero-ovarian anastomosis, then anterior division of internal iliac artery. So what is the best answer here? C. Uterine artery, then ovarian artery, then internal iliac artery. It is uterine, ovarian, internal iliac. Specifically anterior division of internal iliac 3 centimeters below the bifurcation of common iliac, so that we don't compromise the posterior division. Next, 20-year-old female presents with webbed neck, shield chest. Which of the following findings are most likely to be seen in this patient? You should know everything about Turner's. So webbed neck and shield chest is nothing but Turner's. Turner's will have coarctation of aorta, not mitral valve prolapse. So they have streak ovaries, correct. So head to toe of Turner's you should know, guys. So Turner's, they'll have short stature, webbed neck, short stature, webbed neck, flat chest with widely spaced nipples, coarctation of aorta with bicuspid valve. Write down whichever you also know. Cubitus, valgus, short fourth metacarpal, thyroiditis, diabetes mellitus, streak ovaries, infantile uterus, and lymphedema, horseshoe kidney. I think they can also have sensory neural hearing loss in some cases. Okay. Right. Yeah, they are normal IQ. Correct. They are normal IQ. Correct. Next. 28-year-old primary gravida whose known case of mitral valve replacement presents at 36 weeks to the antenatal OPD. She is on warfarin 4 milligrams. Her INR is 3. Which is the correct regarding anticoagulant therapy? Discontinue warfarin and start low molecular weight heparin. Discontinue warfarin and start heparin and aspirin. Discontinue warfarin and start aspirin. Continue warfarin and start heparin. So what is the answer for this? So discontinue warfarin and start low molecular weight heparin. Now I want to add something here in this point. So according to Williams, so you should always stop warfarin at 36 weeks. So according to Williams 26th edition, you have to always check the warfarin dose. Warfarin dose, if it is less than 5 milligrams per day, continue warfarin up to 36 weeks. Continue up to 36 weeks. You cannot use it beyond 36 weeks. Okay? If it is more than 5 milligrams per day, start low molecular weight heparin in first trimester. Then change to warfarin in second and third trimester. Again, continue up to 36 weeks. At 36 weeks, you should always start low molecular weight heparin or unfractionated heparin till delivery. So stop 4 to 6 hours prior to delivery. Vaginal delivery. or stop, just stop before cesarean section. Lactation में post delivery it is warfarin plus heparin. Warfarin plus heparin. Once INR becomes 2.5, stop heparin and continue warfarin. Okay. Am I clear? Am I clear? I went little fast, I guess, but I hope it's clear. Right. A 25-year-old woman who is anxious to conceive comes to the OPD with complaints of profuse white discharge for 2 days. Her LMP is 13 days back. She has no itching. Clue cells are there. Her menstrual cycle are regular. The most likely diagnosis is 13th day. If somebody has vaginal discharge, it is physiological. It's called leukorrhea. It's mainly due to estrogen, high levels of estrogen. So clue cells can be there in normal discharge also. When clue cells are more than 20%, it is bacterial vaginosis. Yes, this is physiological, guys. Bacterial vaginosis में clue cells will be more than 30%. Sorry, more than 20%. As it is on 13th day, this is physiological. Okay. Trichomonas you will have greenish discharge. Again, you should all know about all vaginitis. Bacterial vaginosis will be foul smelling. You all should know what is Amsel's criteria. Candidiasis will be curdy white discharge. And lot of pruritus. 16-year-old girl presents to you with partial transverse vaginal septum with dysmenorrhea and chronic pelvic pain. Which of the following is she likely to have? Theca lutein cyst, endometriosis, tubo-ovarian abscess, and dermoid cyst. So, whenever there is a transverse vaginal septum, menstrual blood cannot come out. So, menstrual blood tends to go back. So, as menstrual blood tends to go back, they can present you with endometriosis. And the symptoms of endometriosis are dysmenorrhea and chronic pelvic pain. Very good. It is endometriosis. Okay, a 28-year-old woman is undergoing evaluation for successive recurrent pregnancy loss. On ultrasound, a Mullerian anomaly is suspected. What is the best way to confirm this? Transvaginal ultrasound, HSG, CECT, hysteroscopy and laparoscopy. Always remember, the gold standard for diagnosing Mullerian anomalies are hysteroscopy and laparoscopy. HSG has no role. Best way to confirm, they are asking. Gold standard for the diagnosis is hysteroscopy and laparoscopy. Don't forget, this is a silly mistake. This is bad. Investigation of choice is 3D USG or MRI. Gold standard is hysteroscopy or laparoscopy. Okay. What is the treatment? A 28-year-old abortion-free with recurrent second trimester abortion has a midline uterine septum on sonosonography. Sonosalpingography. What is the best management? Midline uterine septum in septate uterus. So what is the treatment for septate uterus? Hysteroscopic actually it is laparoscopic hysteroscopic transcervical septal resection. So the best answer I have here is hysteroscopic septoplasty. Remove it. So the indication for repairing this is recurrent abortion, which this patient presented to you with. Whenever you have didelphys or bicornuate, you will go for unification surgery. That's called Strassman's metroplasty. And whenever you have septum, it is transcervical hysteroscopic septal resection. Please remember it. These are important. 55-year-old lady with 5 children presents with leakage of urine on cuffing. On examination, there is a second degree uterovaginal prolapse. and cystocele. What is the most likely urinary abnormality? Investigation of choice for endometriosis is laparoscopy. Yes, this is stress incontinence. So whenever a patient coughs or laughs, if there is some amount of urine coming out, it's called stress incontinence. The best surgery for stress incontinence is tension-free vaginal tapes. Tension-free vaginal tapes. Transobturator tape followed by transvaginal tape. Which of the following is not estrogen-dependent pubertal change? Hair growth, menstruation, vaginal cornification, cervical mucus. Cervical mucus is estrogen dependent. Vaginal cornification. Under the influence of estrogen, vaginal epithelial cells will become superficial cells which are pink color and cornified cells. Menstruation is also due to, endometrial growth is mainly due to estrogen. Hair growth is by androgens. Hair growth is by androgens. For this, you don't require to read tons and tons books. We can answer this, right? What is this? What is this appearance called as? So this is called as tobacco pouch appearance. This is called as tobacco pouch appearance. Where do we see tobacco pouch appearance? Bilateral hydrosalpinx. Bilateral hydrosalpinx or pyosalpinx, it's mainly seen in tuberculosis. What is this instrument? It is a laparoscopic band applicator for tubal ligation. This is laparoscopic band applicator for tubal ligation. See, there are rings and all also seen, right? Rh negative mother is the current obstetric advanced era. In the current obstetric advanced era, what is the best test to monitor sensitized Rh negative mother? Just now I told you. How do we check for the fetal anemia in Rh negative mother? Yes, very good. It is middle cerebral artery Doppler waveform. Whenever middle cerebral artery Doppler waveform shows peak systolic velocity more than 1.5 multiples of median, it means there is severe anemia. It means there is anemia in the fetus and we have to go for chordosynthesis. So we monitor by middle cerebral artery Doppler waveform. This is outdated. Amniotic fluid spectrometry and Lilly's chart, all those are outdated. What condition in the mother is associated with following image of the fetal anomaly? Babies super goal matol. Where do we see goal matol babies? I think the options are wrong here. Both options are same. So it is seen in GDM or gestational diabetes, right? AC inhibitors lead to renal agenesis. Sodium valproate will lead to neural tube defects. This is seen in GDM or gestational diabetes, which are both same. A 35-year-old female attends the gynecological OPD with history of excessive bleeding for 6 months. Not controlled with non-hormonal drugs. USG and clinical examination reveal no abnormality. What is the next step? Options there were wrong. A and B both were answered there. GDM causes macrosomia, then over DM. Okay? GDM causes macrosomia, then over DM. Over DM with vasculopathy can lead to IUGR. Whenever 35-year-old presents to you with, you're not able to control with non-hormonal drugs like tranexamic acid, you can first give progesterone and try. If progesterone doesn't help, then you go for endometrial sampling. So 35 is reproductive and there is no abnormality. So you can go for hormonal therapy. If same patient would have been 55 years old, then my answer would have gone for endometrial sampling. Age ke base mein it will depend. 35 hormones, non-hormonal didn't help, go for hormonal. 55 non-hormonal didn't help, then also I'll go for endometrial sampling. Because that age mein I'm suspecting endometrial hypoplasias and cancers. Yes, just a perineal tear detected after 2 weeks. When do you repair? So whenever you have a perineal tear detected within 24 hours, Repair immediately. Repair immediately. If you have perineal tear detected after 24 hours, you have to repair after 3 months. You have to repair after 3 months. Okay. A 24-year-old mother with 7 weeks of period of gestation to ANC OPD with history of accidental exposure to radiation from a chest X-ray. What will you advise her regarding the pregnancy management? Nothing will happen. Maximum permissible radiation is 5 rads. 5 rads. One X-ray is very less. Okay. I'll send this in my Telegram group. You can check it from my Telegram group. I'll send the PDF in my Telegram group. Don't bother about that. So please be there in the class. So 5 rads is maximum permissible. Chest X-ray is very minimal radiation. So you can just continue the pregnancy. Okay. A 40-year-old visits gynec OPD with history of intermenstrual bleeding. The USG shows a lesion within the endometrial cavity with feeding vessel. What is the diagnosis? Can you see there is a homogeneous echogenic mass? So what is this homogeneous echogenic mass which can present to you with intermenstrual bleeding? Yes, it's endometrial polyp. And in endometrial polyp, you will have feeding vessel sign positive. In endometrial polyp, you will have feeding vessel sign positive. Remember, polyp will look white color. Endometrial polyp will look white color. Fibroid will look black. White means it is called echogenic. Black means it is called hypoechoic. Adenomyosis. Adenomyosis will be black and white. Salt and pepper appearance. Black and white. Okay. Can you remember this? See again oligohydramnios and polyhydramnios. So you should go back and revise all the causes for oligo and poly. Okay. A 22-year-old primary gravida visits the ANC OPD with 20 weeks of period of gestation. On further obstetric examination, uterine height shows 16 weeks. Oligo. What is the probable cause? Again, it can be renal agenesis. Again, it is renal agenesis. Bartter syndrome is the only syndrome, although it is renal involvement, it causes polyhydramnios, not oligohydramnios. Okay. Fetal anemia will lead to poly. Barters also will lead to poly. See, this is again a repeat. See how frequently same questions are repeating. Perrectal reveals a bulging mass in the vagina. What is this? Imperforate hymen. We just now solved this question, so I'm just skipping it. Right, next question. 13-year-old gynec child visits the gynec OPD with complaints of not attaining menarche. Karyotype is XX. On examination, there is clitomegaly. Which enzyme is deficient? So whenever there is clitomegaly, it can be congenital adrenal hyperplasia. The most common enzyme deficient in congenital adrenal hyperplasia is 21-alpha hydroxylase deficiency. 21-alpha hydroxylase deficiency. This will always have increased 17-hydroxyprogesterone. This will always have increased 17-hydroxyprogesterone. Okay. 17-hydroxyprogesterone will be raised. The enzyme deficient is 21-alpha hydroxylase. Preeclampsia. A 35-year-old primary gravida conceived after IVF cycles attends an ANC clinic with 38 weeks period of gestation. Her obstetric details reveal DCDA twins with first twin breech. On examination, blood pressure is more than 140/90 on 2 occasions with proteinuria of 1+. How will you manage? This is a combination of 2 things here. Chalo, sabse pehle you tell me what is the diagnosis here. Is it gestational hypertension, or is it mild preeclampsia, or is it severe preeclampsia? Blood pressure with proteinuria is there, and blood pressure is less than 160/90, and there are no impending signs. So this is mild preeclampsia. When do you deliver a patient with mild preeclampsia? Come on guys, I want you to learn the approach. When do you deliver a patient with mild preeclampsia? 37 weeks. Severe preeclampsia is 34 weeks. Whenever proteinuria is present, it's a preeclampsia. Blood pressure less than 160/110, mild, more than 160/110, severe. Any end organ damage like headache, blurring of vision, epigastric pain, if they are present, then directly it will become severe preeclampsia. As I don't have any of those symptoms, this is a mild preeclampsia. This is a mild preeclampsia, right? So mild preeclampsia, 37 weeks you should deliver. She is already 38 weeks. This is one part. She has DCDA twins with first twin breach. So one thing I have understood that I cannot wait and watch. I have to deliver her. Now, what should be the mode of delivery? The mode of delivery is decided by the twins now. Whenever the twins may, first twin is non-cephalic. First twin non-cephalic. You'll always go for see, as she has already crossed 38 weeks, I want to deliver her. I will not wait and watch. I'll not watch for BP. I'll not do delivery only when BP rises. No. She's already crossed 37 weeks. What is the point of waiting? So just deliver her. Now to decide the mode of delivery, twins may, whenever you have first twin non-cephalic, you should always go for cesarean section. I feel this is a beautiful question. Don't you agree? Matlab, you have to use your brain. Two things combined and both concepts involved. First twin cephal, you can go for vaginal. If the first twin was cephal, then would have been induction of labor. As first twin is non-cephal, you have to go for cesarean section. Okay. 24-year-old with a married life of 4 years visits an infertility clinic with history of recurrent abortions. On further workup, she is having septate uterus. See, they have asked septate uterus twice. Don't you feel Mullerian abnormalities are important? You should go back and revise Mullerian abnormalities. So what is the answer for this question? Yes, it is transcervical hysteroscopic septal resection. Transcervical hysteroscopic septal resection. Correct. 26-year-old married for 2 years visits the infertility clinic. She was put on HMG. On treatment, she developed dyspnea and abdominal pain. Her report shows following image. What is the condition called? What is this? So this is nothing but the OHSS, ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. You're seeing multiple cysts in the ovary. This is all because of the HMG treatment. So it is ovarian hyperstimulation syndrome. Correct. Next question. 18-year-old girl comes to the gynec OPD presenting with 6 months of amenorrhea with history of low-grade fever, weight loss, pain in the abdomen, generalized weakness. Pelvic mass is felt in the left with features of ascites. What is the diagnosis? 18-year-old, 6 months of amenorrhea, history of fever, weight loss and pain abdomen. Now if it is an ectopic pregnancy, it cannot go for 6 months of amenorrhea. Fibroid will not cause fever and weight loss. Fever and weight loss, all these are in favor of what? Guys, how can so it is all in favor of tuberculosis with tubo-ovarian mass. Tuberculosis with tubo-ovarian mass. Right? Correct? I don't want to read the question. Can you answer it just by seeing this? What is this beautiful picture telling us? What is this diagnosis and where do we see this? So what is this cervix showing us? So the cervix is showing us strawberry cervix. Strawberry cervix or strawberry vagina. So this is strawberry cervix or strawberry vagina is mainly seen in trichomonas vaginitis. Trichomonas vaginitis. What is the treatment for trichomonas vaginitis? It is metronidazole, both in pregnancy and non-pregnancy. Candidiasis, curdy white discharge with lot of pruritus, and the treatment for this also is, this is fluconazole. Bacterial vaginosis is the only one which will not have pruritus. It's only Dirty grey discharge. Drug of choice here also is metronidazole. The distension medium used in hysteroscopy with bipolar cautery is, see, hysteroscopy also you have to use distension mediums. You have electrolyte rich mediums and electrolyte poor mediums. Electrolyte poor mediums, electrolyte poor, so whenever it is normal saline or whenever it is RL, this conducts electricity. So this cannot be used for monopolar cautery. This cannot be used for monopolar cautery. But these are the one which are used for bipolar cautery. So used in bipolar cautery is normal saline. If the question would have been used with monopolar cautery, then it is glycine, guys. Glycine is best for monopolar cautery because glycine does not conduct electricity. So for monopolar cautery, it is glycine, sorbitol and mannitol. Yes, Shimu, excellent. This is the last paper I'm going to discuss, okay? 30-year-old woman with complaint of dysmenorrhea, dyspareunia and chronic pain underwent hysterectomy. From the cut section of hysterectomy specimen below, identify the condition. So you have a uniform globular enlarged uterus which has presented to you with dysmenorrhea, dyspareunia and all. So this is nothing but the adenomyosis. This is very classical of adenomyosis, right? Day 20 of menstrual cycle falls under which phase? Day 20 of menstrual cycle falls under luteal phase. Luteal phase. Follicular phase is the first half. Ovulation is around day 14. Luteal phase is after ovulation. So luteal phase day 20. 45-year-old female has 3 months of menorrhagia. USG shows 2 centimeters submucous fibroid. The first line management for her is. This is an interesting question. So most of the time whenever it is submucosal fibroid, you'll all jump and answer for fibroid hysterectomy, all that. Although she is having submucosal fibroid of 2 centimeters, I'm not bothered about the submucosal fibroid. I am bothered about her age and menorrhagia. In this age, what am I more worried? Endometrial hypoplasia and endometrial cancer. Right? So what am I going to do? I'm going to go for endometrial sampling. This is an interesting question. So usually you will think you will go for submucosal. It is a 2 centimeter submucosal fibroid. Yes, I'm not worried about the fibroid. I am worried about her risk of having cancer or hypoplasia. First I'll rule out that. If that is not there, then I'll go for hysterectomy. So first in this age group, please remember 45 years and above, always endometrial sampling. Okay. Presenting diameter for a fully flexed head. So this I teach with a very beautiful mnemonic. So I'll tell you that mnemonic. Whenever the transverse engaging diameter for all is biparietal diameter, but the anteroposterior engaging diameter keeps changing. Cutoff age for endometrial sampling 45 years. 45 years. Okay. Whenever you have complete flexion, then it is mainly suboccipitobregmatic, SOB, 9.5 centimeters. How do I ask the students to remember is, when boy is full crying, that is a posture of crying, no? Like this. So when boy is fully crying and is decided to go to, this is called military position or deflection. Deflection or military position. My mnemonic for the second one is, he's crying so much that he decided to go to military office at 12. So military office at 12. So military position of OF, occipitofrontal, occipitofrontal. And how many centimeters is this occipitofrontal? It is 12 centimeters. So military office at 12. So military position occipitofrontal 12 centimeters. Okay. Next, this is called partial extension. Partial extension it is mainly bro. So this boy was crying and decided to go to military office at 12, but his friend comes and tells, bro, move. It's 14th Feb. Go enjoy with your girlfriend. It's Valentine's Day. Bro, move. 14th Feb. So it's bro. Partial extension is bro. Mentovertical. Mentovertical. How many centimeters is this? 14 centimeters. Entire pelvis maximum diameters are 13. 14 can never enter into the pelvis. So for bro, it is LSCS. Complete extension, it is face. It is face. Now, why this boy was crying? Why is it decided to going to military office in spite of Valentine's Day? His girlfriend called him Sambar face. Sambar face. So face, sambar, SMB, submentobragmatic, which is again 9.5 centimeters. Cool. Okay, guys. So first is sob. Next, military office at 12. Bro move 14 Feb. Sambar face. Presenting diameter of a fully flexed fetal head is suboccipitobragmatic. Suboccipitobragmatic. Okay. Next, 60-year-old woman with 3rd degree uterine prolapse. What will be the management? 60 years old, 3rd degree uterine prolapse. What will you do? Vaginal hysterectomy with pelvic floor repair. Right? The major contributor of amniotic fluid after 20 weeks of gestation is fetal urine. Fetal urine. Right? So the major contributor of amniotic fluid after 20 weeks of gestation is mainly fetal urine. Fetal urine. What is the dose of ulipristal acetate for emergency contraception? So ulipristal acetate can be given up to 120 hours. Can be given up to 120 hours. And the dose of ulipristal acetate for emergency contraception is 30 milligrams. 30 milligrams stat dose. 30 milligrams stat dose, and it can be given up to 120 hours. It can be given up to 120 hours. What is the treatment of mastitis in a lactating mother? The treatment for mastitis in a lactating mother is cloxacillin. Actually, it is dicloxacillin. Yeah, you can also use cloxacillin. Mastitis, you can breastfeed the baby. Continue breastfeeding. Prachi, I'll tell you, don't worry. After another 10 minutes. Continue breastfeeding in mastitis, and the drug of choice is dicloxacillin or cloxacillin. 60 years when the 60 years with vaginal prolapse, when everything is hanging out, you should remove it. Where will we do pessary? When she is not fit for surgeries, like 80 years, she has severe hypertension, severe diabetes, there we'll go for pessary. In low ovarian reserve, AMH levels will be, AMH is the best marker for ovarian reserve. AMH between 2 to 4 is considered to be normal. AMH less than 1 is called as poor ovarian reserve. It should be actually less than 1. I don't have the answer here, but AMH less than 1 is considered to be poor ovarian reserve. So I think B can be used. But ideally AMH less than 1 is called as poor ovarian reserve. Identify the type of placenta shown in the picture. So it is touching the margin of the os. When it is within 2 centimeters from the internal os, it's called low lying. When it touches the margin of os, it's called type 2. It's called type 2. Gestational trophoblastic neoplasia does not include. So it includes choriocarcinoma, placental site trophoblastic tumor, invasive mole, and it includes epithelioid trophoblastic tumor. epithelioid trophoblastic tumor. Olden days में full single liners it was, no? It's no fun in doing this, है ना? So partial mole is not included in GTN. Patient with recurrent abortion diagnosed as APLA, what will be the treatment? So the treatment for APLA is aspirin and low molecular weight heparin. Treatment for APLA is aspirin plus low molecular weight heparin. All these are single liners. Chromosome for partial hydrated form mole is partial mole is 69XXY, whereas complete mole is diploid. It can be either 46XX or 46XY. Most common is 46XX. Partial mole में most common karyotype is 69XXY. Vulval atrophy and itching are treated by, so vulval atrophy and itching we can mainly get because of the estrogen deficiency. So vulval atrophy and itching you can treat it by estrogen ointment. Estrogen ointment. PGF2 alpha maximum dose in PPH. So PGF2 alpha 250 micrograms you will give every 15 to 90 minutes and maximum you can give 8 doses. That is 2 milligrams. That is 2000 micrograms. Methergin, you should know all drugs side effects and all also. PGF2 alpha will cause bronchoconstriction. Methergin 0.2 milligrams, maximum 5 doses. That is 1 milligrams. Methergin 0.2 milligrams, maximum 5 doses, that is 1 milligram you will give. Oh, 2000 micrograms and 2 milligrams are same, no? 2000 micrograms and 2 milligrams are same. So I think probably some answer mistake, but A and C both are answers here. Carboprost is 2 milligrams. That is nothing but 2000 micrograms. Methergin is 1 milligram. Yes. Carboprost is 8 doses. Methergin is 5 doses. Okay. At 34 weeks, the weight of the baby was 3 kgs. The child showing the following features may be indicated in anemia, diabetes, APH, none. Again diabetes. This is also repeat question, no? 5 years में 2 बार repeat कर दिया. Which of the following is false about the physiological changes in pregnancy? Increase cardiac output. Yes, cardiac output increases. Protein. Blood will become pani. Increase total protein. Yes. Total protein will increase. Plasma protein, albumin will decrease. Residual volume will decrease, guys. Lung में residual volume, expiratory reserve volume and functional residual capacity will reduce. All these three will decrease. GFR increases. Yes, GFR will increase. So what is false? Increased residual volume is false. Overt gestational diabetes is called when fasting blood sugar is more than 126. FBS should be more than 126. PPBS should be more than 200. HbA1c more than 6.5. Magnesium sulfate has no role in. It is having definite role in seizures in severe preeclampsia. It can be used in recurrent seizures also. It causes uterine relaxation. It doesn't decrease RDS in premature baby. It decreases cerebral palsy in premature baby. Magnesium is neuroprotective. It decreases cerebral palsy. Okay. Green frothy vaginal discharge is produced by trichomonas. Green frothy vaginal discharge is produced by trichomonas. Which of the following is an absolute contraindication for OCP use? So it is contraindicated in thrombosis, DVT. It can be used in diabetes but not with diabetes with vasculopathy. So it is contraindicated in thrombosis, active liver disease, ischemic heart disease and valvular heart disease. Left heart is best. Breast cancer, migraine with focal neurological deficits, diabetes with vasculopathy, hypertension more than 160, 110, and pregnancy, and age more than 35, smoking more than 15 cigarettes. You have to by heart this. है ना? Which of the following is correct in acute fatty liver of pregnancy? See, acute fatty liver of pregnancy is rare, but it is seen in third trimester. So it is seen in nulliparous, twins, and it is more common in male fetus, guys. It's more common in male fetus. So here mother will have deficiency of, mother is heterozygously deficient of long chain hydroxyacyl dehydrogenase. Fetus is homozygously deficient of long chain hydroxyacyl dehydrogenase. So as baby is deficient of this enzyme, baby will send the fatty acids to mother. That fatty acids to mother leads to acute fatty liver of pregnancy. It is rare. I don't know how much, but it is rare. It is seen in third trimester. I know it is in male fetus, so it is wrong. May be associated with decreased uric acid. Yeah. So it increases creatinine. Okay. Double decidial sign is due to decidia capsularis and decidia parietalis. It is mainly seen in first trimester. Double decidial sign, this is double decidial sign. Gestational sac is covered with 2 rings. It's mainly seen in the first trimester. It's mainly due to decidia basalis and decidia capsularis. Knuckle translucency is seen between 11 to 13 weeks when crown rump length is between 45 to 84 mm. Baby's neck should be in neutral position and NT should be less than 3 mm. NT should be less than 3 mm. Most common aneuploidy with increased NT is Downs. Second most common is Turner's. Most common congenital malformation with increased NT is cardiovascular malformation. How many are there? A female with 41 weeks of gestation confirmed by radiological examination, very sure for LMP, no uterine contraction, no effacement, no dilatation. What should not be done? You should do induction now. You can do induction with intracervical Foley's. Yes, it will help in ripening of the cervix. You can put misoprostol. You can give dinoproston gel. You never give PGF2 alpha for induction, guys. So what should not be done? PGF2 alpha should not be done. PGF2 alpha should not be done. So that finishes I have discussed almost till 2019, guys. So I will end the session now. Before that, some of you have requested me for this. I know already. Some of you have requested me to tell regarding the normal saline and RL. So whenever you are giving normal saline and RL in hysteroscopy, fluid deficit can be there. I'm not telling full everything, all concept, but those who already know about hysteroscopy, they know this. So fluid deficit of 750 ml, you should get alert. And when it is 2 to 2.5 liters, stop the procedure. And when you're using glycine, sorbitol, and mannitol, fluid deficit of 750 ml, you should get alert. And when you have fluid deficit of 1 to 1.5 liters, stop procedure. Otherwise, patient will go into pulmonary edema and hyponatremia and hyperammonia. Okay. So that's for today. I have discussed in a crisp manner your past 4 years or 5 years, I don't know. I think we have discussed past 4 years of question papers of NEET. 1 year is there. You can just go through it. So I think you all have become perfect with this much. So we have discussed some concepts also along with the questions. So definitely watch this question. Watch this. It is highly beneficial to all. So myself, I am Dr. Ramyasree. You can follow me on my Instagram page also. It is Dr. Ramyasree9. Any queries, you can always tag me in any of the Bhatia groups, Telegram groups or Instagram. Anywhere you can tag me. I will definitely respond back and I'll help you all till exam. Any queries of obstetrics and gynecology, I'm one message away. Thank you so much, guys. Thank you so much. Thank you so much, Hazira. Thank you. Good night, guys. Sweet dreams. Thank you so much.